Hey everybody, thanks for joining us tonight. I'm going to hopefully prevent my cat from walking across the keyboard. She has just precise timing. And I hope everybody who is in the Northeast region or suffering through the weird, wacky weather we've had today will keep their power on. So tonight we are going to talk about, can we advance? How do we advance? Why is okay. So throughout this lecture, we're going to discuss the terms surrounding the very often confusing PEMF, learn the history of PEMF, which I absolutely love. It's one of my favorite parts of the story. Try to understand the science behind PMF, and if anybody tells you they know 100% how it works, they're probably mistaken, including the mechanism of action and the physiological effects. Then we're going to discuss and back up what we're talking about with human and veterinary research, including wound healing. And this includes all types of wounds, not just skin. So what is pulsed electromagnetic field therapy? Unfortunately, it's very, very confusing. It's also misleadingly called magnetic field therapy, but PEMFs, which are pulsing electromagnetic fields, encompass an immense spectrum, kind of like the term radiation. And it makes it almost impossible for the uninformed layperson to assess and differentiate among individual concepts, application forms, and the systems or devices offered on the market today. The term is all-encompassing, leaving clinicians to do a lot of research and understanding before being comfortable with this modality. Come on now. All right, so PMF is an active electromagnetic waveform delivered by antenna. The myriad of technologies are differentiated by parameters of the waveforms they emit, such as the antenna size, the duration, and the frequency of the application. And these combined determine the strength and efficacy of the signal. Often overlooked, PEMF waveforms do not cause heat or membrane depolarization. And we'll get to that, we'll tie into that later on in the lecture. But it actually has to be detectable above background noise. So what does the FDA consider PEMF? Come on now. All right, so according to the FDA, section 890.5290, a PEMF medical device is a prescription device transmitting a therapeutic signal in the radio frequency bands of 13.56 or 27.12 for the adjunctive and palliative treatment of pain and edema in soft tissue without generating heat. For FDA approval, and I just read something on VIN today, a little string that was started, I think, back in February about the FDA's involvement with safety versus efficacy, which I disagree, and I will answer that VIN posting. But a lot of research has gone into specifically the Assisi device. One for FDA clearance, it has to prove that it's safe, and it's electromagnetically compatible with its use and gives signal output characteristics, including peak output power, pulse width, pulse frequency, duty cycle, antenna output, specific absorption rates, characterization of the deposited energy, electrical and magnetic fields with correct labeling and clinical testing. This is a fairly high bar, not only in the human market, but definitely in the veterinary market, where the money to do all that is quite large. When you actually get and apply for an application for PEMF, the only two codes that you can submit under are ILX and PQY, and those stand for non-thermal short wave therapy. So right off the bat, a clinician can go to any device's website, and if they talk about being FDA cleared, or more basically, anything in a box with electricity has to be FDA registered, they have to pick a code to apply. And some of those codes have nothing to do with shortwave non-thermal therapy. So that can help dispel some myths right away. So the history of PMF is that in the 19th century, English scientist Michael Faraday proposed time-varying, i.e. pulsing, electromagnetic fields could induce an electrical field in a nearby conductor, such as copper or even tissue. So this is hinting at the fact that you don't actually have to have electrodes implanted in tissue. The late 19th century and early 20th century, many theories produced energy medicine devices, which many were promoted without scientific evidence, and has a wide array of operating characteristics, including some of these that heat tissue. Newer modified non-thermal devices were introduced by reducing the duty cycle to prevent it from heating tissue. So if any of you are rehabbers or use therapeutic ultrasound, you know that you can use therapeutic ultrasound to heat, or by pulsing the signal, you will not produce heat. Okay, so in the 1970s, clinicians began implanting electrodes in bone to provide direct electrical currents to treat non-union fractures. And during this time, Arthur Pilla, an electrochemist, was traveling to San Diego for a conference and sat next to a guy on the airplane who was reviewing, I don't know how many of you are old enough, his Kodachrome slides. And boy, they were a nightmare if they ever fell out of the tray. But if any of you met Arthur, I miss him dearly. He was a great guy. He was so nosy that Arthur was peeking at his seatmate's slides. And the seatmate was Andrew Bassett, orthopedic surgeon. And Arthur saw something obvious to him and said, "I see you're working on dendritic outgrowth from an electrode." And that's a process in electronics where the metal grows whiskers that causes it to short. And he assumed that Dr. Bassett was going to the electrochemist meeting. And the stranger said, "Nope, that was bone growing from an electrode," and he was going to an orthopedic meeting. So these two geeks obviously hit it off, and Arthur traveled back to Bassett's lab after the meetings and proposed, rather than surgically inserting the electrodes into both sides of a non-healing fracture, as Bassett and other orthopods had been doing, they simply pulse an electromagnetic field from the outside. So they studied this first on beagles, then humans, with non-union fractures to get regulatory approval for the bone growth stimulator. So this type of pulsed electromagnetic field, the bone growth stimulator, is a long-term chronic treatment, often used for many, greater than 8 hours per day for several months. This extensive treatment protocol is required because the bone growth stimulator uses an inefficient signal waveform, although back in the 70s and 80s, it represented very advanced thinking at the time. Although inefficient energy delivery, randomized clinical trials to assess bone growth stimulators' efficacy at about 70 to 80%. And I remember working in my dad's orthopedic office and always having to sign up, get prescriptions for these usually metatarsal non-healing fractures to get a prescription for the bone growth stimulator. So it was really nice that years later, I got to meet the guy who was behind that research. And in fact, this is the actual patent submitted by Pilla and another coworker, Ryaby, for low-powered PMF device, a bone growth stimulator, effectively starting their company, Electrobiology Incorporated, or EBI, which is still in business today in Jersey. So 1970s PEMF, or the bone growth stimulator, was marginally effective because the transduction mechanism was unknown, so they couldn't dose it properly, and they dosed it poorly. With more understanding of biological processes, scientists were able to target specific biochemical and electrical pathways associated with pain, edema, wound healing, and tissue regeneration. Unfortunately, many PMF systems today show a really wide range of ineffective therapy. PMF in general, though, has been used on hundreds of thousands of patients without known adverse or side effects. There are a couple, but usually not with wound healing. So Gauss's law, which is also important, the strength of the magnetic fields generated by PMF devices can vary dramatically from less than 1 Gauss to several thousand Gauss, which means that not all PEMF devices or signals are alike nor efficacious. A clinician must understand the difference between these signals and fields and rely on human and animal research to validate specific devices for clinical conditions. Pmf waveforms cleared for human use by the FDA were designed to penetrate completely through all tissue types, allowing for non-invasive delivery to internal target areas. Now, this is, for the sake of explanation, the actual waveform delivered by the Assisi loop Pmf shortwave therapy. Shortwave indicates that it is a radio frequency from 1.6 megahertz to 30 megahertz, and it is actually 27.12. With 2 bursts per second, the magnetic field is switching from north to south nearly 11 million times every second, and the induced magnetic field is 4 microtesla. This is 1/1000th the strength of a cell phone, and when people suggest that it may cause harm, with everybody running around with cell phones, especially during COVID times, using their phones for everything, probably very false. This is also, for sake of explanation, the treatment field, volume and dosage, supplied by the Assisi loop. And this is a 10-inch loop, 25 centimeters, and the treatment time, what Arthur Pilla and a lot of his colleagues had worked on in the 80s and 90s and 2000s, was that a treatment time was 15 minutes. And for acute, inflammatory, surgical, acute trauma, wounds, every 2 hours was best. And for chronic sort of smoldering conditions, every 6 to 24 hours was sufficient. The loop field radiates up and down, whether that's a loop or a pad. And the wonderful thing, and why I like it so much, even in cases, or especially in cases where I can't use laser, is that I can penetrate through bandages, casting, bedding. So if I am actually if I'm doing wet to dry as an acute wound healing, hit by car road rash case, every day I'm going to be changing those bandages for changing my wet to dries. But when, the owner's sort of running out of money, the wound is starting to granulate and epithelialize, I don't have to change that bandage every day. So I can't use laser. So that's a perfect time to use the loop. It's really fantastic. So let's talk about the mechanism of action. When injury occurs, calmodulin activation is accelerated and it immediately enhances nitric oxide production. This promotes blood and lymph flow and reduces inflammatory cytokine production, which leads to a rapid reduction in pain and edema. Now, when this signal first went to the FDA to get cleared to be considered for pain reduction, they had to use the standard carrageenan injection rodent model for evaluating anti-inflammatory medications used very widely within the FDA and the industry. And it showed that the Assisi signal, which was using it 3 15-minute PMF treatments, markedly inhibited pain and reduced edema by over half, which was actually equivalent to those seen with non-steroidals. So then, this study performed on embryonic ventral mesencephalic and neuroblastoma cells showed that the pulsing electromagnetic field signal produced an immediate 3-fold increase in nitric oxide, which is what the Assisi loop enhances nitric oxide. So it shows that when there is inflammation on the left, using PMF, nitric oxide is enhanced. But then when there is no inflammation, the electromagnetic field signals don't have anything to work on, so it doesn't do anything. So that's why we really have very, very limited side effects. There's not too many things we can say that about today. So this depiction demonstrates vascular endothelial growth factor binding to endothelial cells, which activates nitric oxide synthase. And there was a big learning curve when I started with this product, because people were throwing out INOS, ENOS, CNOS, all these different nitric oxide synthases. So it's a little bit difficult to get your head around all of them, but it does actually make sense. So when VEGF binds to endothelial cells, it enhances nitric oxide. And nitric oxide is known to stimulate endothelial cell growth and motility, leading to angiogenesis, which you need for wound healing or any type of healing, frankly. VEGF signaling also contributes to increasing vascular permeability. And the nice thing is once you stimulate, even though you're going to treat a wound, somewhere, let's say on the hip, whatever, nitric oxide just doesn't stay right there. It does circulate through the body, obviously. So there are downstream effects, which is nice. And I apologize for this busy slide. Nitric oxide is involved in the inflammatory, proliferative, and regeneration and remodeling stages of wound repair. So immediately following, whether it's a hit by car traumatic injury or a surgical cut, there's an acute inflammatory cascade which occurs, and it's the important part of the recovery process. Macrophages and neutrophils produce IL-1 beta, and this upregulates inducible nitric oxide synthase, which is the bad one, the one you don't want. And this produces excessive amounts of nitric oxide. And this, if you don't cut that out, it unnecessarily will prolong the inflammatory stage. So this is where, and why you want to use in an immediate situation, PMF is useful at this stage because it reduces the excessive pro-inflammatory nitric oxide and it cuts out the duration of the inflammatory phase, leading to accelerated healing. Growth factor production is also accelerated, which enhances tissue repair, i.e. wound healing. Let's see, so it's been reported that PMF exposure results in increased expression of certain adenosine receptors in a variety of cells and tissues. Activation of these receptors by endogenous adenosine is associated with reduction in prostaglandins, inflammatory cytokines, again consistent with published clinical findings of reduced pain, inflammation, and wound healing. Regarding the growth factors produced, fibroblast growth factor 2 and vascular endothelial growth factor both mediate angiogenesis, starting in the immediate first few hours, continuing for a couple of days. The inflammatory phase in wound healing is considered to be a preparatory process for the formation of new tissue. Expressed tumor necrosis alpha has been shown to have a beneficial role in wound healing. And then later on, transforming growth factor beta regulates inflammation and has a crucial role in cell differentiation and new cell growth, and you guessed it, wound healing. I'll take a sip of water here. Okay, another busy slide, I'm sorry. PMF is very busy at work here. In endothelial cells, vascular endothelial growth factor signaling activates the P13K, I can't even say the word, pathway, and endothelial NOS is phosphorylated, which activates it and decreases its dependence on calcium. Endothelial nitric oxide synthase is activated through phosphorylation of tyrosine and heat shock protein 90. And they say that heat shock proteins are little cellular policemen that run around and sort of police what's going on and try to stamp out the bad things. Simultaneously, vascular endothelial growth factor receptor 2 signaling mobilizes intracellular calcium, which further activates endothelial nitric oxide synthase in a calmodulin-dependent manner, which increases AMP kinase, which plays a role in cellular energy homeostasis. Going on, further on the graph there, nitric oxide produced by endothelial nitric oxide synthase binding stimulates cyclic GMP synthesis, activating cyclic GMP-dependent protein kinase and cyclic GMP-gated channels to regulate downstream targets that contribute to wound healing by increasing endothelial cell proliferation, migration, survival, and permeability. So I like PMF. I think it's pretty nifty. All right. It's becoming clear that PMF interventions likely operate via a few biological cascades rather than just one pathway. And as research into PMF mechanisms of action continue to unfold, the gained knowledge should really be helpful for further exploration of new clinical indications. Biophysical and cellular mechanisms through which PMF therapies influence biology are very complex and remain an ongoing area of research focus. However, there's been significant progress made in identifying some of the pathways that are relevant to the more widely used PMF technologies. MOA studies strongly show targeted PMF with downstream production of nitric oxide, which is one of the very few known signaling molecules. So how do we tie that all into some history? In 1977, a substance was discovered in endothelial cells that caused vasodilation, which was later named endothelium-derived relaxing factor. And a few years later, it became known actually that EDRF was in fact nitric oxide. Louis Ignarro and colleagues characterized the role of nitric oxide in biology, particularly in its cardiovascular effects. And they were later awarded the Nobel Prize in Physiology or Medicine for this work. In addition to its function as a vasodilator, nitric oxide can potentially influence cells of the immune system, the nervous system, endothelial system, making it a very important signaling molecule for homeostasis. And I didn't even know we had molecules of the year, but 1992 was nitric oxide's year. All right, so let's go through some human evidence, which I love, except, whoops, this is actually a bench study, but it is very much about wound healing. So they took full thickness cutaneous wounds in rats, and they also transected Achilles tendons in rats. That one's on the right. This is peer-reviewed, blinded study showing that PMF signal accelerated the cutaneous wound healing and tendon repair by reducing the pro-inflammatory cytokines and increased growth factor production. In both studies, tensile strength measurements of PEMF-treated tissues of the wound and of the tendon were 59% and 69% stronger and quicker than sham-treated tissues. And this study was done using 30 minutes every 12 hours. So, as I promised, to the human studies, and I just put all these slides together. I just think this work is absolutely fascinating and everybody really should benefit from it. So over the next set of slides, we'll see results of the targeted PMF, which is the CC signal effects on women in 2 different randomized placebo or sham controlled clinical trials who had mastectomies on the left and mastectomies plus transverse rectus abdominis muscular surgical flaps, that's a mouthful, to close the wounds, because those are significant amount of resection. In both of these studies, by using targeted PMF, and these women, the nice thing, again, these loops were just wrapped right into their bandages, so they didn't have to have them changed when they didn't need them changed. They were right there. We measured pain levels. We used visual analog pain scoring and also looked at wounds. But the nice thing is that their pain scores were decreased by 50%. That's a lot. Then the surgeons showed that in both studies, there was less edema produced or inflammation by using the targeted PMF. And then they took that edematous fluid and they measured IL-1 beta, the inflammatory cytokine in the edematous fluid. And again, in both studies, there was much less IL-1 beta in the PEMF treated patients. And then they measured the amount of pain medication these women took. And again, both populations of women also required fewer narcotics. So they had lower pain scoring, but they also had lower amounts of narcotics on board. So that's more than a 50% reduction. And that, you know, with today's opioid crisis is pretty amazing. All right. This is not exactly wound healing, but I do like this study because it does sort of compare different, this will come up later when we compare different types of signals. I talk about targeted versus something like non-targeted. This is a study done at the Henry Ford Clinic in Detroit, I think, and by using the PMF device twice a day on patients that had early knee OA. And to enter this study, the people had to work for 8 hours a day on their feet. So it wasn't like they could, you know, rest up, et cetera. So they found by using PMF twice a day, there was a 44% reduction of pain by 24 hours and a 60% reduction of pain overall by 72 hours. All right, I love this study as well. I'm not sure how many of you are familiar with, but chronic pressure ulcers are a very well-recognized problem in persons with spinal cord injury, stroke, the elderly, and other individuals who may be bedbound or wheelchair-bound. the National Pressure Ulcer Advisory Panel estimates the prevalence of pressure ulcers to be between 3 and 30% in acute care facilities, between 3 and 23 per patients in skilled care facilities and nursing homes, and between 7 and 12% of patients in the home care setting. That's a lot. Various studies estimate the cost to heal an ulcer in one area from $5,000 to more than $25,000, and the total financial cost runs over $5 billion annually. And these numbers were from 1999. So this is a double-blind, placebo-controlled prospective clinical pilot study which aimed at determining whether PMF could stimulate wound healing of the chronic wounds in spinal cord patients. Active and sham groups were treated for 30 minutes daily for 4 weeks, plus standard saline moist gauze dressing. So obviously, it's not like these people were up and walking around. If they're paralyzed, they're in bed. So there's continued pressure on these ulcers. Comparison of the wound area prior to the start revealed that their ulcers were similar. However, in contrast, after 4 weeks of PMF therapy, wounds treated with PMF were 64% wound closure and healing versus no change or less decrease. Wound size increased by almost 10%. That's amazing, I think, right? So they're trying to figure out why is PMF so good with wound healing in this. So they're surmising that chronic inflammation, which is associated with pressure ulcers because there's continued presence of necrotic tissue. Inflammation is an essential phase in the healing process, as I mentioned before. However, during this phase, the body often responds by what I was saying before, creating excessive amounts of pro-inflammatory nitric oxide, or in this situation, responds by creating excessive amounts of tissue fluid, hoping to cushion, but that's edema, and it distends the interstitial space, causing pain, delayed healing, and increased morbidity, which it really does. So for soft tissue and musculoskeletal injuries, as well as post-surgical, post-traumatic, and chronic wounds, suppression of edema buildup may or may not be one of the really important parts of trying to control when we're going to talk about wound healing. And I'm just putting this in there. I'm not going out and saying that PMF is going to save the world, but make a suggestion that PMF can be used in various systems, and work is being done using PMF in the context of various types of cancer, including skin, breast, prostate, hepatocellular, lung, ovarian, pancreatic, bladder, thyroid, colon, in vitro and in vivo. So stay tuned, I guess. This slide I just put together represents research on some other PMF abilities, including improved growth factors, which I mentioned, chondrogenesis, proteoglycan synthesis, collagen synthesis, important for wound healing, and more. So there is a lot of bench research and some human studies. You just have to find them. All right, so what do we know about its use in veterinary medicine? So I'm just going to start with, if anybody really is interested in learning, it is a great read. It's a very fabulous review of the history, science, and research on PMF, published in Research in Veterinary Medicine in 2019 by our esteemed colleague, Dr. Jamie Gaynor. He has been using targeted pulsed electromagnetic field therapy for years and years, and he actually tells a story when he lectures, so I don't mind sharing it. That his sister-in-law was a recovering drug addict, and in her recovery, while she was sober and clean, she was diagnosed with breast cancer. And while the thought of breast cancer was very, very frightening to her, the thought of her becoming rehooked again on drugs was more scary. So she had her mastectomy, and she used the loop in her recovery. And Jamie was amazed with her progress. All right, so this is a study published in 2002 in the Journal of Orthopedic Research, where they created 2-millimeter gaps mid-diaphysis in 12 adult mixed dogs. These dogs were stabilized with external fixation. 6 were treated with PMF for a total of 8 weeks. They used functional load bearing and radiographic assessments while the dogs were alive, until torsional tests on bone and histological assessments could be made. In the PMF group, the load bearing of the operated limb recovered earlier and better when compared to the control group. the periosteal callus area increases healing of bone. Healed following surgery by 6 weeks in the PMF group, while it took longer, 8 to 10 weeks after surgery in the control group. And while people say, you know, what's a couple weeks? Well, I bet surgeons in the group, when they have to tell an owner that they have to tell this massive lab who's used to going out and being a weekend warrior after having a TPLO, has to be leash walked only and crated and penned for 6 weeks rather than 8 to 10 weeks, they're going to feel pretty good about it. Both normalized maximum torque and torsional stiffness of the PMF group was significantly greater, so it's stronger than those of the control group. Histopathology revealed greater new bone formation in the osteotomy gap tissue and increased mineral apposition rate and decreased porosity in the cortex adjacent to the osteotomy line in the PMF group. These dogs received PMF 1 hour per day for 8 weeks and provided faster recovery of load bearing, significant increase in new bone formation, and higher mechanical strength of the healing mid-tibia osteotomy. So consider that in any of your healing or non-healing fractures. Leg calvé-perthèse or avascular necrosis of the femoral head is a non-inflammatory aseptic necrosis of the femoral head and neck, which occurs in both young children and small breed dogs. The etiology of leg calvé-perthèse is currently unknown, but trauma, infection, metabolic and hormonal imbalances, as well as hereditary factors causing vascular damage have been suggested. Ischemia, necrosis, and collapse of the femoral head and neck are the main changes of this disease. And the clinical findings are pain and lameness. Radiology is required to confirm the disease. And this paper actually is really good. They have very nice x-rays of all three. It's a case series of 3 female Portuguese Podengo puppies from the same parent were presented for investigation of right hind limb lameness. Certainly seems like there's a genetic component there, but clinical and radiographic exams of the hip revealed leg perthèse disease in different stages in 3 puppies. Surgical FHO was performed in only the advanced puppy, I'll call her number 1. External coaptation was applied in puppy 2. I'm not sure the thinking of that with what we know today, but hey, well, PMF was applied in puppy 3. And the last 2 puppies, puppy 2 and 3, had earlier stages of disease. The FHO puppy did well, however, had the common muscle atrophy at 1 month of age. And anybody who's had a dog or involved with rehab, you know that these are the dogs that you work and work and work and stretch and stretch and stretch because you don't want to deal with an atrophied three-legged dog 6 months later trying to correct that. Puppy 2 with the external coaptation, no figure, had persistent pain with worsening disease and was recommended an FHO. And puppy 3 was interesting, and they actually followed it out 6 months because of the success. It was re-examined at 2, 4, and 6 months. And at 2 months, the owner reported an improvement of walk and behavior of the dog. At 4 months, lameness was not present and manipulation of the hip did not elicit pain. And at 6 months, the dog showed a full recovery, and the pelvic x-rays revealed normal trabecular pattern compared to the first x-ray. So if anybody has any of these dogs or cases, consider PMF therapy as a treatment option. So this study is near and dear to my heart, published in the Journal of Neurotrauma, done at North Carolina State University by Natasha Olvey and colleagues. They used dogs with complete grade 5, the hopeless of the hopeless cases, intervertebral disc extrusion. Upon diagnosis, so they didn't wait till after surgery. This study, we helped with the protocol. These dogs were treated with PMF or sham starting from pretty much admission, and then started right after surgery, hemilaminectomy. They were treated twice daily for another 28 days after using it every 2 hours for 2 weeks. Neurologic assessments, wound pain, biomarkers were measured. What they found that was in 24 hours, there was significant decrease of incisional wound pain based on mechanical sensory testing. Now, these guys didn't take photos of the wounds and compare them, but the next study I'm going to talk about did, which is pretty cool. But just to finish here, proprioceptive placement was better in PMF dogs by day 42, and glial fibrillary acidic protein, a marker of spinal cord injury, was significantly less in the PMF treated dogs. Now this study, out of AMC, published in the Journal of American Animal Hospital Association in 2019, they took 53 dogs with grades 2 to 4, IVDD, post-hemilaminectomy. They used a different protocol, but the loop or sham was applied every 6 hours post-op until discharge, which was a couple of days, and then twice daily until post-operative day 7. And these dogs, the PMF-treated dogs, revealed better neurological scoring, better incisional pain and wound scoring, and they have photos comparing before and after. PMF dogs walked in half the amount of time, and sham dogs received twice as much codeine, which mimics our human study of the women who had the mastectomies and the tram flaps. And a caveat to this study, although randomized into groups, when they went back and statistically compared everything, the PMF group had a worse neurological scores to start. So although we created these wounds, the dogs created their own intervertebral disc disease, and PMF did show to make them better. So this is, I'm comparing here, going back to the early knee OA study done at the Henry Ford Clinic. There are many different key waveform parameters that influence the effectiveness of actually any device, but okay, PMF device such as pulse width and frequency. So taking into consideration these two devices, device 1 having a pulse width of 100 microseconds and pulse frequency of 1000 hertz, and device 2 having a pulse width of 2 milliseconds and pulse frequency of 2 hertz, the difference in waveforms yields a 7-fold greater electrical field strength for device 2. This obviously should have meaningful consequences for treatment efficacy. And there are 2 very similar papers describing this. So the Henry Ford Clinic I talked about before is the graph on the left, where the active dark dotted patients had less visual analog pain scoring compared to the sham. Then the study on the right, they also took humans with early knee OA, and their medical device, PMF device 1, who has a different signal, they had to wear their device 12 hours straight a day. So 12 hours. And in 1 month, there was a 25% reduction in pain. So yeah, that's great. And this device is cheaper. However, I would rather treat for 15 minutes twice a day, and within 48 hours have a 44% reduction of pain, and within 3 days have a 72% reduction of pain. That's just me. So why is that so different? PMF technology is using waveforms similar to a CC. We call them targeted PMF devices, as their waveforms are specifically designed to efficiently deliver energy to tissues and modulate biological signaling cascades. Less effective technologies, and the device on the top is Heal Fast or ActiPatch, are not specifically designed to evoke specific biological effects and are non-targeted or generic PMF devices. So that is the difference. So a lot of people, if you go to some of the websites, especially the suitcase model used in equine barns, not a lot of research there. And if you actually go onto everybody's website, besides looking for their FDA code of registration, PQI or ILX, that their bibliography, which really should be their own research library, they just pull research from other devices. So you have to be savvy about knowing that, unless they've done research on their own device, you can't believe any of it. So the high frequency PMF, these are pulse direct current coils, which induce current causing the muscles to twitch. So already we know by causing depolarization that this is not considered PMF, or at least what the FDA considers PMF description. So, okay, so what? They use very low frequencies and very long wavelengths, And again, without research, I don't even know. But if you go onto their website as well and search for their FDA registration codes, they are actually classified as muscle stimulators. So that's not PMF. And so sometimes, and speaking actually with a lot more of the equine vets, they like a lot of these devices because they think that it relaxes, especially if you have a horse with back issues and they're on the road and showing that using one loop, you know, on one little hip area is not going to save the day, but using this big heavy coil, which you can see that it's actually doing something, you can get that horse to relax or their back to feel better, so the competitor can hop on and do all the classes that it signed up for. So that's fine. It's just, let's just call it what it is. It's muscle stimulator or massage even, if you will. And we know that there are benefits to massage. We just can't confuse it by calling it PEMF. And I have yet really to see any clinical evidence to back up their claims. I would love to see some, but maybe stay tuned. So low frequency PMF, as we mentioned, signals must be measurable. A lot of the devices on the market, especially, I think there's much more acceptance in the large animal field of using PEMF. But you should ask, where is the clinical evidence? Do they know the protocols that they're talking about? Are these really magnets? And magnets also have been, you know, sort of accused of being voodoo. There's some newer and different magnets and magnetic research that I'm not caught up on. And we'll see. Competition-wise, anybody who actually is in equine medicine, they can't use any of the high-frequency PMF devices while they're at the shows. So also important. I think the FEI made that change 2 years ago. So another great thing about PMF, does it interfere or complement other modalities? So here's PD, and this was when a CC was building itself up and trying to decide what research projects to do. This is PD. PD was thrown out of a car or a truck. And you can see there the deep wound with the exposed tendon on the left. And again, being sort of a rescue, you don't want to spend a ton of money. You want to do, you know, conservative treatment if you can. And this is a dog who had wet to dry bandages applied. And when they took the bandage off, they could use the laser. But all the other times when the bandage was on, they could treat right through that bandage with the CC loop. And on day 29, there's a deep wound with exposed tendon, which I think is really cool that within 1 month, that looks pretty darn good. Oh, sorry, my slide didn't catch on. So PD on the left, day 1, see the exposed tendons, and PD on the right after 29 days of treatment. And laser was used in the beginning, but that's when you complement each other. And one of the other notes to make about laser therapy and the loop is that they both are thought to enhance nitric oxide. One of the things we do know about nitric oxide is that when you enhance it, it sort of goes and it does its downstream signaling, and you can't really reboost that for at least 2 hours. That's why we have a 2-hour window in between treatments. So it doesn't hurt if you use PMF in between those 2 hours, but you're not going to get any added benefit. And probably also as well, using a laser and the loop within 2 hours, probably not going to get any more benefit. Not going to hurt, but you might as well come up with a good plan. And here is another reason why you want to use the loop. This is a 3-year-old long-haired Chihuahua who had bilateral MPL surgery. That's pretty brave. He was also known as a land shark. His name's Bob the Angry Chihuahua. Post-op rehabilitation included eStim, laser, therapeutic exercise, and a CC loop. Day 2, now you know these Chihuahuas, they don't want to walk on any leg that they have, never mind an MPL leg or an MPL fixed leg. But following day 2, he was reluctant to walk, but would bear weight with support. They kept the CC loop in place in automatic mode. So the automatic loop worked every 2 hours for 15 minutes. They just laid it on the dog. So where else can you have a therapy that you can just lay on sort of hands off? and integrated into the wounds, or in Bob's case, placed over the land shark surgical site. And there was no evidence of swelling or redness at the incision sites past day 2. Days 3 to 7 following surgery, Bob continued to recover remarkably. Rehab was limited to passive range of motion twice a day and the loop. They discontinued the NSAID Medicam after 5 days, and he gradually increased activity. So just coming from Chihuahua's sake, that's fabulous. Days 7 to 14 following surgery, there was a remarkable recovery, fully weight bearing, no signs of any offloading onto the front. He was walking longer distances, actually almost half the distance he was walking pre-surgery. The Assisi loop, the owner, who was a rehab therapist, thought that the loop made a very important part of his recovery. Now, horses are a different beast, as we know. I don't know if there are any equine vets out there, but a lot of times these horses suffer from making excessive granulation tissue, proud flesh, etc. My dream would be for a CC to do an equine wound study, hopefully on the books for sometime in the future. But this colt was put out with another 2 colts in Ocala, Florida. Unfortunately, by the time he was kicked and found was 2 days later. It was contaminated, and the decision was made to just clean it, slather some ointment on it, and wrap it using the Assisi loop. So wrapped it. They used the Assisi loop twice a day for 5 days, and you can see that there's been remarkable recovery with not a lot of expense or energy put into it. Here is for the insurance plans. This was updated, I think, as of July 2019, that PMF therapy is, get that, oh, go back. I'm trying to get that screen off. In most insurance plans, reimbursed, depending on who prescribes it. So usually they need a veterinarian to prescribe it. But so if any of your clients are asking about insurance, tell them to read the fine print. So just as of one bit of information, these are the FDA cleared PMF devices on the market as of 2018 and the date that they received their decision. These are a list of other ones, probably the ones that have more advertising. You've probably heard of them that are not FDA cleared. You could also put, there we go, Beamers on the bottom, etc. So I think when you're talking about veterinarians kind of struggle with not having a lot of research, I think CC has kind of gone above and beyond any other PMF company to try to use their limited finances wisely. They've done the 2 IVDD studies, they've done pilot studies, 2 in osteoarthritis, and then there were a couple of studies that were going forward right before COVID shut everything down. We are revamping and starting a feline osteoarthritis study, so that none of that has to do with wounds. However, it's good to know that we are not resting on our laurels, and we're trying to find a good place to use our device and prove that we work. So veterinarians can rest assured that we do have some research behind us, and we're very welcome to hearing from anybody if there are questions. But the other thing is, you know, if owners are coming to you with other devices, this is cheaper, this is better, this is whatever, you know, you should probably have knowledge that it is FDA cleared, so at least it's safe, that the mechanism of action is disclosed. We know the waveform characteristics. There are some considerations about using PMF with either seizure cases, implanted medical devices, etc. In the big suitcase models, the Magna Waves and Curatrons, there are electrical safety certifications that need to be met. And how have they proved any of their research? Do they know protocols, or are they just certifying technicians to run around and treat patients? So I think that we've discussed PMF therapy. I love the history and the science. I wish we knew every single ounce of information there was to know about the mechanism of action. We've seen definitely a lot of physiological effects and how it's been very useful in human and veterinary research, useful in veterinary medicine for especially wounds. What we know is that targeted pulse electromagnetic field therapy is clinically proven to accelerate reduction of pain, inflammation, decrease biomarker levels, increase wound healing, as well as reduce 50% reduction in opioid intake in humans and dogs. It's an FDA cleared technology. You can use it as an adjunct to other wound healing modalities. It is portable, so you can send the healing home or to the stable. All right.